There's also withdrawal syndrome. This can happen when you're discontinuing SSRIs, so you want to make sure that you tell an individual if they're having negative side effects to SSRIs, or they want to quit taking the medicine and they've been taking it for a month or two, that you can't just stop taking the medicine. So when you prescribe SSRIs, you tend to taper. For instance, let's take Prozac, 10 milligrams for about 2 weeks, and then you can go up to 20 if you feel like it's needed after that. But let's say they've been taking 20 milligrams of Prozac for 2 or 3 months. They're going to need to cut down to 10 milligrams for about 2 weeks before completely coming off. And sometimes you can lose your effectiveness with your antidepressants. I call it a poop out. There's a couple different ways you can handle that. One way is to you can change medications that don't affect the same neurochemicals. You can sometimes switch within the same class. If they're taking Paxil, you might switch over to a Celexa, or you can have a drug holiday, which takes place usually over the course of about a month or two. You can take them off the medicine to sort of reestablish those receptors and reestablish a balance in the brain, and that's usually effective about 50% of the time. But again, you don't want to take someone off medications that's a high risk. So you're going to have to weigh that sort of a risk versus benefit. SSRIs are pregnancy category C, with the exception of Paxil. The way that I remember that, and Paxil is a D, the way that I remember that is it has X in both its trade name and its brand name. So you have paroxetine X, and you got Paxil, the X there. The only other antidepressant that has X's in both its name is fluvoxamine, which is Fluvox, but you're not going to see that for depression. 99.9% of the time it's prescribed for OCD, which is not something that you will probably commonly run in. Paxil is one, however, you will run into fairly often. So just think about the X. The X in pregnancy categories means don't. So if you're weighing out SSRIs in pregnancy, don't use Paxil. SSRIs are safe for children and geriatrics, but one thing to consider, which makes logical sense, is propensity for geriatrics to sort of lose weight. And so you may have to adjust doses based on that, because if they lose a considerable amount of weight on a dose, maybe they were being treated with 40 or 60 milligrams of Prozac, and they lose 20 pounds for whatever reason, maybe due to surgery or some type of incapacitation for injury, it's possible they could actually develop a serotonin syndrome because it's now too much. Just really quickly, to cover the SSRIs, because these are the ones you're going to see fairly often along with the SRNIs. Fluoxetine, if you're thinking about treating things symptomatically, and has sort of spoke to presentations where you're making a decision between an SSRI or SRNI, some of your serotonin symptoms that you would need to think SSRIs first are going to be things like anxiety, panic, phobias, PTSD, obsessions, compulsions, and eating disorders. So those are the things that are going to tend to be probably more responsive to SSRIs first. For some things that I articulated earlier about the appetite with the histaminic agonist, but we usually use SRNIs for people that have what we call norepinephrine deficiencies, which look like fatigue, apathy, cognitive deficiencies, focusing attention, slowed information processing, and deficiency in working memory. So those things we would use SRNI for, because these people need to be activated in sort of the physical sense. And the reason why I say that is Prozac may be the exception with SSRIs and prescribing things to people that are fatigued or that have concentration problems. It tends to be the most activating of all the SSRIs. So if you have someone who has a good response to SSRIs, but they're feeling they need just a little bit more energy, but you don't want to move them from an SSRI to an SRNI, then Prozac is a good choice. Sertraline is one that I like overall. It's usually my go-to, particularly in the VA, because we see a lot of PTSD. It's probably the most effective for PTSD, and it's also pretty effective for OCD. The only one that's probably better for OCD is the one I mentioned earlier, was fluvoxamine. But you're going to see it at higher doses. So if you see someone that comes in on 150 or 200 milligrams of sertraline, then you can probably assume that that person is being treated for PTSD or OCD. Citalopram, Celexa, it has a lot of cardiovascular side effects. A lot of primary care providers start people on that without really recognizing the dangers. If you have someone that's healthy, 25, 35, 40 years old, that's moderately active with no history of cardiovascular issues, Celexa is pretty effective. But anyone that has any type of cardiovascular concerns or history, it just tends to not be a very good medicine for a side effect profile. But it does have a chemical cousin called escitalopram, Lexapro, which you see fairly often, which has less sexual side effects associated with it. And it's also better for geriatrics because it has less side effects in general. So now moving on to the SRNI categories, which is selective norepinephrine reuptake inhibitors. These increase norepinephrine and serotonin through reuptake inhibition. They don't bind to histaminic, muscarinic, or adrenergic receptors, so that gives them a better side effect profile and comparative to really the rest of the antidepressant categories. They're more activating, as I said, and they're usually prescribed for people with a low energy, fatigue, and the other symptoms that I mentioned earlier. They're also associated with with less sexual side effects, so that's also beneficial. And there's a smaller category of these, so there's nothing made to remember, but it's venlafaxine or Effexor. They've got desvenlafaxine, which sort of has the same relationship that that Invega or paliperidone had to Risperdal, that escitalopram had to citalopram, and then it's just a chemical cousin. Tends to have a little bit better side effect profile. Some people make the argument that the side effect profile being better, but that it's not as effective for the symptoms of interest, but that's something that you just kind of have to face. It kind of varies from person to person. Then you got duloxetine, which is Cymbalta. So really quickly about these, venlafaxine, what's unique about this is that at its lower doses, sometimes it started at about 37.5 to 75 milligrams, tends to affect serotonin more, whereas when you start moving up to about 150 to 200, you're affecting more norepinephrine, so it becomes more activating, excuse me, more activating as you move up. And then as you even go higher than that, it actually starts to modulate dopamine. So if you want more of the serotonin effects, if you have someone that presents with the things that I had said earlier, the anxiety, the phobias, etc., you may want to stick with a sort of a lower dose of the venlafaxine to sort of help out with those symptoms. But if you need someone that needs more activation, you can increase the venlafaxine, which is kind of why I like it, as you can do a lot with it. And it's very effective. It's actually pretty effective for PTSD as well. The desvenlafaxine is sort of the same scenario applies. Duloxetine is to me an interesting medication because it's not very good as a monotherapy for depression, but it's very good for treating depression and chronic pain. So if you have someone that says that they suffer from chronic pain and that they think that their depression is primarily related to the chronic pain, it's actually a very good medication, and it tends to be activating as well, not to the degree that the vaccine is in its highest dosage, but again, if you have someone that has I think one of its other FDA approval is diabetic neuropathy, so it works pretty good for people that have diabetes and cardiovascular issues that have some associated pain or just general chronic pain. It tends to do pretty well, which sort of segues into the next category of medications, which is the TCAs, which they were designed for depression, but they also have a lot of attributes that actually help with chronic pain. It's just their side effect profile is not as favorable as duloxetine. TCAs are actually pretty effective overall, but they're dangerous medications. They're medications that you don't really want to give to an individual that is suicidal because they can be lethal. They have a very, very narrow sort of safety index or therapeutic index. So if you have someone that's suicidal, has a history of suicide, and you're sort of concerned about them, most of the time people only prescribe a week's worth of medicine to them at a time. I'm not going to talk about TCAs a ton. We use them a lot in the VA. In particular, we use them for sleeping. People that suffer from PTSD have a very difficult time sleeping, so it's hard to sort of find your traditional medicines that actually work. So we use things like amitriptyline or Elavil. But one thing of interest about Elavil is it's probably one of the most cardiotoxic of all the TCAs. So if you're going to choose a TCA for someone that, for chronic pain, depression, and you've tried a few other avenues and haven't worked, you definitely don't want to use amitriptyline for someone like that. In reference to the categories of TCAs, you have what they call sort of secondary TCAs, which are going to be more of your sort of norepinephrine, and you've got your tertiary, which is more of your serotonin. So again, kind of going back to the same things I was talking about in terms of deficiencies and your chemicals and how you want to treat certain things. Just understand that making those decisions are going to be important across the board. With TCAs, amitriptyline has a chemical cousin, nortriptyline. It actually treats more of the norepinephrine deficient symptoms, but it can be a little bit more sedating it is more sedating than the SRNIs. So if you have someone that's having trouble sleeping, that's having some chronic pain, but they also have some of those norepinephrine deficient symptoms, nortriptyline is probably the cleanest of all the TCAs. It's one that I see fairly often. So just kind of keep that in mind. One of the other ones you may run into is doxepin. You use that one for sleep and chronic pain as well. So really those two, nortriptyline and doxepin, are the two that I would use. Amitriptyline, again, very, very effective, but it's very cardiotoxic, so just be careful with prescribing those. With the MAOIs, we don't see them that much anymore. So I'm not going to talk about them, but what you need to know probably for your tests and for your certification is that they interact with pretty much everything. Bananas, aged cheeses, you know, uh, like wines. I mean, pretty much anything that you can think about, they tend to interact with. One thing of interest, though, for the purposes of your certification and possibly for the test, is that you can't start an MAOI. If that's a decision, again, I recommend against that. Don't start an MAOI. But if you do, you have to wait 6 weeks if someone was on an SSRI before you can actually start an MAOI, because serotonin syndrome, because of the amines. If you think about the title of MAOIs, it's monoamine oxidase inhibitor, so it means it's breaking down the enzyme that's actually going to break down the amines, so there's going to be more amines available. So it means you've got more norepinephrine, you've got more serotonin, you've got more dopamine. So there's already a lot of sort of chemical action going on there, and then if you're adding serotonin with that, then you have a high incidence for some problems related to serotonin syndrome, etc. So you're going to have to wait 6 weeks before you start that. And again, if someone is on an MAOI and they come to you and you want to get them off of that, which I most of the time recommend, unless they're tolerating it well, you're going to have to wait about 2 to 3 weeks before you can actually start an SSRI after monoamines. They tend to stay in the system less time versus the SSRIs, so that's where you see the discrepancy between the start time. But just make sure you remember that. So a longer time going from an SSRI to an MAOI, and a shorter time going from MAOI to SSRI. But look in the PowerPoint and look in your book. They do a good job of laying out the different foods to avoid and sort of the interactions. Really, again, you're not going to see them that much in practice. The certification exam likes to ask about them because they're dangerous. So just make sure you have some familiarity with the interactions with those.